Good afternoon. Welcome to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang. Senator Wynn. Here. Senator Stone. Here. Senator Titus. Here. Chair Doñate.
And I'm here, and please mark Senator Lang present when she walks in. She's in another committee room presenting. Good afternoon, everyone. Welcome to our first ever Digital Health Day. We have several presentations lined up to talk about digital health. And before we start, we do have a few housekeeping items. So just as a reminder, agenda items may be taken in a different order than listed. We ask that if you do have public comments today, that they may be kept to 2 minutes each. We don't have any bills to testify for today, so that doesn't apply. But if there are any exhibits in today's presentations, you can find them on our Nellis website, or you can also reach out to our committee folks. And so we're going to go ahead and start. So given that we have folks on the East Coast that are helping present some of these subject areas, we're going to start first with the presentation from HIMSS, and then we'll go to Phillips, and then following that, we'll go to MedWand, Paratherapeutics, and then Unite Us. So that's the order that we're going to start off. So we'll start off with a presentation from the Healthcare Information and Management Systems Society. With us, we have Mr. Leary, who is a Senior Vice President and Head of Government Relations. So please proceed when you are ready.
Good afternoon, Senator Doñate. It's great to see you, sir, and great to be representing HIMSS here today. Let me share my screen real quick. All right. Again, thank you. It's a great pleasure to represent the Healthcare Information and Management Systems Society at the Digital Health Day. I'm very honored to be part of this conversation, and we'll jump right into not only the organization, but some of the issues that we see as very important for 2023. The vision of HIMSS is to realize the full health potential of every human everywhere, and our mission is to reform the global health ecosystem through the power of information and technology. I don't often read slides because I used to work for a rear admiral who said, I can read, you don't need to read it. But I think it's important to emphasize the vision and mission of the organization, because it's really what gets all of our members and all of the staff up in the morning to try and live up to the expectations of the vision of this 60-year-old organization. We at HIMSS, just as a snapshot, we have 120,000 individual members, 550 corporate members or market suppliers, 500 nonprofit partners, and 420 provider organizations. Important part of this slide, just as a baseline for everyone, is that as a cause-based not-for-profit, we're not beholden to, we're not a membership organization, we're not a trade association. We're focused on the mission and the cause of the organization. So, for example, the 500 nonprofit partners, they are given a comp membership because we recognize as part of the cause that many healthcare organizations, many nonprofits don't have a dedicated full-time equivalent on health IT issues. And if we're able to give them the resources and access, just like any other HIMSS member, they can help to impact whether it's a small nonprofit addressing a specific healthcare problem or healthcare condition, or a good size nonprofit that just doesn't focus every day on health IT, we can bridge that gap and help achieve the vision and mission. From an organizational perspective, our board of directors has asked us to focus on health equity. I know that it's a few months away from Global Health Equity Week, but as the representative, the executive leadership team member helping to run our Global Health Equity Network, I've been given the charge by our board of directors to make sure that health equity remains the #1 topic for our organization, and it's our objective to deliver on that health equity. What it means for us is everything that falls below on this slide and throughout the conversation. Absolutely is intended to be developed through the lens of providing that an equitable opportunity using technology for anyone to access care. So if you look at our foundational values, the one on top of making communities healthier, all the way through economic opportunity and expanding access to high quality care, all speak to various parts of our vision and mission to be able to achieve that health equity. Importantly, for all of us, throughout this not only this conversation, but throughout, it's being a Digital Health Day in Nevada, but throughout the year, is you can't deliver on any of this, whether it's interoperability and information sharing, connected health, cyber and data privacy, or value-based care without the proper workforce. So the foundation of our roof of this image is absolutely the workforce, whether it's the providers, the clinicians, the IT professionals, who all have a role to play in delivering a digital health transformation here in Nevada and throughout the country and really throughout the world. It's that workforce development that is a key foundational objective for the organization. For 2023, our key policy initiatives that we think are absolutely critical to not only to our engagement with Congress, but in many ways will help improve the access to care for Americans and for really anyone throughout the health ecosystem. There again, health equity being a key driver. We realized that the president has declared that the public and has informed Congress that the public health emergency will be ending on May 11th. There are a lot of components to that that we'd like to say from a health IT perspective, particularly telehealth, remote physiological monitoring initiatives, as well as some of the creative waivers that were put into place that it helped improve access to care during a very uncertain time, particularly in the early parts of the public health emergency, that we're keen on making sure get extensions and get beyond the public health emergency. For example, we're pleased to see that the legislation in the omnibus legislation extended telehealth and remote patient monitoring and remote physiological monitoring capabilities and waivers for providers, additional provider types and additional settings to be able to occur through 2024, through the end of 2024. There are other provisions such as some of the creative responses to from the Office of Civil Rights that allowed for additional ways or for providers to be able to engage in telehealth services that will be going away on May 11th, that we're rather concerned about, we will be working both with Congress and the administration and at the state level to figure out ways to extend some of those and make permanent some of those waivers. In addition, as what we're concerned from on the May 11th issue is that the many individuals will be losing their Medicaid coverage as of early May because they've been provided care through the through the public health emergency. They've been provided access to Medicaid when they lost their jobs through the public health emergency. The FCC recently in January, the Federal Communications Commission granted a waiver to allow telecommunications organizations and healthcare organizations to work together to be able to provide that, to alert those individuals via their text messages or calls to their cell phones, to their mobile phones. We're hearing that some mobile carriers are concerned about the legislative or excuse me, the legal implications of if an individual didn't specifically sign up to be contacted. So we're concerned that that not everyone will be alerted to the end of that of their Medicaid coverage. So it's an additional issue that we recognize where telehealth and where the use of technology helping to expand access can be limiting if waivers such as what the FCC has provided aren't utilized by the marketplace. In addition, the increase of funding for the Office of the National Coordinator for Health IT, it's been flatlined for nearly 10 years. Their budget is in the $62 million range. They had a brief increase to several billion at the start of the Meaningful Use program, at the start of the high-tech provisions back in a decade ago. But since then, they've been given more responsibility, but not additional funding. So we'll be pushing very hard for when the president's budget comes out this Thursday. We anticipate that it will be a $40 million plus up, or nearly $40 million plus up for the Office of the National Coordinator to meet the expanded responsibilities that have been given to it by legislation that's been implemented since its inception, but the funding has not been expanded. An area that we're very vocal on and have been since 2019 is public health data modernization, and we'll talk a bit about that, or as much time as I'm able to utilize. Is if you know much about the Recovery Act and the precursor to Obamacare, the Meaningful Use program, the infusion of health IT solutions into the healthcare space in the United States allowed for certain providers in certain care settings to receive an incentive payment particularly from Medicare and Medicaid, to be able to invest in information technology. From a Medicare perspective, it was a 4-year incentive payment, followed by if you didn't invest, that there would be a formula that was put in place where individual providers or hospitals would receive a disincentive or a decrease in their Medicare reimbursement. From a Medicaid perspective, there was a full decade's worth of funding and an opportunity to invest for Medicaid providers to be able to invest in information technology. The result was the clinical care setting here in the United States is somewhere in the neighborhood of 90 to 95%, both in the individual provider offices as well as hospitals have access to certified electronic health record technologies. The same cannot be said for public health. Public health was left out of the funding back in 2009 and 2010, and we were going to get to it as a country. And so the data modernization initiative that began in 2018 and 2019 with 4 nonprofit organizations, including HIMSS, working closely with the CDC and with states, territories, local public health departments, and tribal public health departments, has raised awareness. And as a result of both the pandemic and additional appropriations, there's just over $1.1 billion is being invested in both the IT services at CDC, and so that they can have technologies that, irrespective of what comes across the transom, whether it's Mpox or measles or vaping disease that was plaguing teenagers several years ago. Whatever the problem, the public health problem is, CDC will have the baseline resources to be able to respond and have the data available to them to help with the response. In addition, 60% of the funding that's been identified is going out to the stilts, to the states, tribes, locals, and territorial public health departments. But we're not finished. $1.1 billion is a good amount of money for start, but what HIMSS is you'll see in some of the other slides, that HIMSS is calling for a $36.7 billion investment in the stilt public health efforts, so that we can achieve that balance between the clinical setting that was established as a result of meaningful use several years ago, and now that so that public health can be an equal partner. In addition, maternal health, the Momnibus legislation that both at the federal level and at the state levels are absolutely critical. The CDC report from several years ago, followed up by a CDC report from last November, indicates that 85% of maternal mortality is preventable, and a good portion of that, we believe, and is indicated in the report, is preventable utilizing information technology, whether it's figuring out ways for providers and patients to be able to have dialogue over text messages, or utilizing apps to help control gestational diabetes or any of the other conditions that might occur for a pregnant person, as well as into postpartum challenges that might occur. It's worth the investment, and what we're calling on is both at the federal level, a federal Momnibus, one of the 10 pieces of legislation that have been identified has passed, but there's a lot of work to do at the federal level. And quite frankly, at the state level, only 2 or 3 states have taken us and others up on the challenge to pass maternal health legislation. Finally, patient identification continues to be a big push for us. There are just in my hometown, there are 2 Tom Larrys. One is 53 years old, 250 pounds, and the other one you're looking at is 53 years old and just a little bit shy of that. So if I get his meds, there's the calculus of the dosing size of the 70-pound difference between the 2 of us could be a challenge for me, medically. So, extrapolate that on the number of, pick a first name, pick a last name. Here in the United States, there's more than one person with that. And in some communities, there's, Maria Garcia, for example, when there was a study done in Houston, there were 400 Maria Garcias. And making sure that the right Maria Garcia got the right care and that the right information was being pulled up on the electronic health record can be augmented by a national strategy on patient identification. Mr. Chairman, I know that there are many issues that we'd love to cover throughout this conversation. 2 things that I do want to make sure that we cover is just that the recent release by the Office of the National Coordinator of the first set of qualified health information networks, some of which are health information exchanges, has met the responsibility from the 21st Century Cures Act to make sure that we move further ahead on interoperability and information sharing. The goals of the program and for the common agreement for, as you see, are threefold: establishing universal policy and technical floor for nationwide interoperability, finally achieving that nirvana that we've been talking about for many years, and in my case, 2 decades of work. Goal number 2, simplifying connectivity for organizations to secure exchange information. to securely exchange information, And finally, number 3, most importantly, from the 21st Century Cures Act and TEFCA, is to enable individuals to gather their healthcare information and to be able to share it with whomever they decide in the format that they want. That is a great challenge for our health IT community, but it's a great opportunity to make sure that patients are truly consumers and active participants in their care, and that they and the caregivers and the providers that they interact with are able to see the right information at the right time to make informed decisions about next steps in the care process. So since February, the first 6 qualified health information networks have been identified. We're anticipating more throughout the summer and into the fall. The first part of September is when those qualified health information networks are expected to, quote unquote, go live. So there is time for the 6 to become 8, 9, and 10. As many as 10 anticipated before the end of the year. One other area of important conversation around health information exchange this year is the idea that is being discussed both at the federal and state level, and then we encourage Nevada to consider the discussion. I know that health information exchange, the health information exchange is the organization, or the noun versus the verb, as we like to, when we geek out in the health IT community, is the idea of can health information exchange organizations be identified as public utilities? There's a good, strong debate happening within the HIMSS community about the value of that. We would suggest that it's one of many approaches for ensuring that health information exchange organizations are viable. Some private entities provide that type of service. Others identified it through public utility in individual states such as Indiana and Arizona have started moving in that direction. And I know that Nevada, the HIE is interested in possibly pursuing that effort. We're open to the discussion and hope and could bring more experts from the HIMSS community to that discussion if you're so inclined. What we talked about already a little bit at length, but just a little bit more detail, is the HIMSS report and just the whole idea around public health data modernization. If you look at the snapshot of January of 2019, when we launched the data modernization initiative, measles was the big problem for the public health community. And the CDC director at the time in January of 2019 stood there and said, I have data from 2015 and I have one individual on my workforce that can help me to interpret what that 2015 data is. I don't have modern data to be able to make responsible decisions and policy decisions. 12 months later, we began the COVID-19 pandemic, but in the 12 months intervening, we had from measles to a small outbreak of just blanked on the disease. It's a small outbreak in the southeast from rare disease from Africa, which will come to me in a moment, and then of course the issue of the vaping disease, or the lung disease that was occurring in the summer of 2019, particularly in the teenagers who were suffering from lung disease as a result of increased vaping popularity that summer. 12 months later, we of course had COVID-19, but we still had data from data collection challenges. So we're very interested not only in the $1.1 billion that have been invested, we want to make sure that we're able to work towards a $36.7 billion investment over 10 years in the public health arena. and most importantly, I think it's incumbent upon all of us to make sure that that the resources that do get identified get to the states, the territories, the local public health, and of course the tribes. And as we look at what's been happening over the last 3 years, I think another data point just to make sure that you're aware of is modernization will become an issue with $3.9 billion to the states for workforce, foundational capabilities, and data modernization and technical assistance and training. The CDC Foundation has placed approximately 4,000 highly skilled epidemiologists and others, including public health nurses at the local and state health departments. Many of those jobs are ending, and there's nearly all of the $289 million that were part of COVID-19 relief funding has been spent to be able to make sure that that workforce, plus the proposed 80,000 employees throughout the public health system that have been identified as the needs of the public health community. Unless we have proper funding and sustainability funding, both at the for CDC as well as for the stilts, many of those jobs will go away, and we'll be back to where we were on March 12th, 2020, scratching our heads because we don't have the right workforce and we don't have the right data available. Finally, and I appreciate the amount of time you've given me this afternoon, I want to make sure that you're aware of some HIMSS resources that are available to the community, particularly our digital health indicator that has been utilized, that intends to look at 4 key areas that both states, communities, and in fact countries are utilizing to understand where they are on their digital health journey and what still needs to be accomplished, both resource investments as well as workforce development requirements. Key indicators are governance and workforce, interoperability, democratization of the data, information can flow, analytics and traceability. Without the advanced analytics, or everything from a small community to a state, or in fact a country, can't actually understand all of what they have available to them and where they need to be going in their digital health journey. I will say that that we've had some success with the digital health indicator out of in the Aucklands in Southeast Asia, several communities in United Kingdom, as well as several communities in Europe, have all utilized the digital health indicator to understand where they need to make the investments, what's their baseline, what they get a baseline score of 1 through 50 in each of these categories for a maximum score of 200. Most communities are somewhere south of that, but being able to then understand both at the healthcare, Department of Health, for example, level, as well as at the legislative levels, being able to understand where the investment can be made to be able to increase their score and increase the likelihood that their community, their state, their country can deliver on that digital health transformation. There are other maturity models that HIMSS has offered up to the community. That most notably is the EMR adoption model, which is been used by resources here in the United States. The Department of Defense, for example, just at Nellis Air Force Base, has done a pre and post deployment assessment of their what was known as their Alta system, and then they deployed the MHS Genesis, the Cerner product, and then they did a post deployment assessment to make sure that they're moving forward with the capabilities, the resources to be able to deliver on digital health transformation in the community, for the military community. Equally important is that, or equally from a civilian perspective, many hospitals, we have a census level review of the EMR adoption model throughout the United States. Other countries have utilized that tool to understand where they are on the each facility is on their everything from paper and to paperless. So with that, Mr. Chairman, I'd like to just invite anyone who's available to come to our learn more at our conference in Chicago in a few short weeks. We also have a very robust Nevada chapter that I would love to make sure that I know that you have utilized before, but that the entire committee can utilize on its Nevadans who are whether they're clinicians or IT professionals or market suppliers who are able to help answer your questions and to help shape any legislative initiatives that you may have underway. I thank you for this time, and I'm available for questions if necessary.
Thank you so much. Greatly appreciated your presentation. I think that was important to set the ground for all of us as to what we're going to expect today for Digital Health Day. Particularly, I think, that your comments on TEFCA and public health modernization nationally is vitally important. And also, we're finding ourselves in similar conversations with where telehealth stands post-COVID. So I appreciate your comments, just painting the picture for us as to where we stand federally and how states can align towards that. So I don't have any questions, but if anyone has any, I think we're good. Thank you so much, Mr. Leary. Appreciate your comments.
Thank you.
Okay, and in talking about digital health, one of the conversations that we've had time and time again is what remote patient monitoring can look like specifically for our state. So today we do have Ms. Jody Augustiniak, who is a leader in partnership development for virtual care and monitoring from Philips. So please proceed when you are ready.
Good afternoon. I hope everyone can hear and see me.
Please proceed.
Great. I'm just going to share my screen here. Give me one moment. Wonderful. All right. Well, thank you so much, Mr. Chairman, and the members of the committee for inviting us to be with you here today. And thank you also, Mr. Leary, for your insightful presentation on HIMSS initiatives and the digital health space. Philips has been a strong supporter of HIMSS, and we will be there in Chicago next month. I wanted to first start off with a brief introduction about myself as well as Philips, my employer. So my name is Jody Augustiniak. I'm actually a registered dietitian by training, but I've spent the last 20 plus years in the healthcare space, really focused on disease management prevention and disease management products in order to help better our health plans, our providers, and all of their members in helping them manage those chronic conditions. I've worked for Philips for about the last 2 years, and I work in their virtual care team, which I'm going to talk a little bit about in a minute. But prior to working at Philips, I actually worked for Centene Corporation. And back in 2019, 2020, I actually worked very closely with their Medicaid plan there in Vegas, in Nevada, in Las Vegas, which is Silver Summit Health Plan. I actually worked with them on some digital health initiatives that they were putting on for their Medicaid beneficiaries. You probably know the Philips name. I think it's a pretty common household name. There's a lot of commercials on TV. We got our start actually about 130 years ago with the light bulb. And since that time, we've definitely evolved into a healthcare technology company. We are driven by our customers and by our consumers in helping them prevent disease and stay healthy. We work with clinicians to help them make the right diagnosis and deliver the right care. And, you know, we are putting products forth like MRI machines that you find in hospitals. We're putting forth ECG machines and ultrasound machines that you may find in a provider office. And then, you may find our Sonicare toothbrush sitting on your bathroom counter. And now we've evolved into remote patient monitoring, which is what I'm going to talk a little bit more about. But our mission really is to improve the health of 2.5 billion lives by 2030. It's a grand initiative, but we are a global company and we are making strides every day across all of our product lines. So here you can see the quadruple aim. So with our virtual care team, we are aiming to address what we call the quadruple aim. And this is for all of our customers, which includes health plans, it includes large health systems, provider offices, and employers. We are aiming to improve the patient experience, both from a quality and satisfaction perspective. We're aiming to improve health outcomes. We're aiming to improve the staff experience, knowing that health professionals today are stretched so thin and they need efficiencies in their work. And then, of course, ultimately, the goal is to lower the cost of care across the board. And our remote patient monitoring is aiming to do just this with the quadruple aim. So as you can see on the screen, I'm just going to give you a high-level overview of what our remote patient monitoring entails, just to kind of set the stage on what it includes. So as you can see, I have 3 pictures up there of different monitoring devices. The first is a glucometer for diabetes. The second one is a blood pressure cuff for hypertension. And then the last one is a weight scale that we can use for weight management and congestive heart failure. We have additional devices as well, but I wanted to highlight these 3, and I specifically wanted to call out the fact that these are all cellular-enabled devices. They have a cellular chip, so as soon as the user pulls them out of the box and turns on the device, takes a reading, that data is sent up through the secure cloud environment and is made available to a clinician. This is really important because a user does not have to have Wi-Fi. They also don't have to have a smartphone in order to make this solution work for them, which is really nice for Medicaid beneficiaries that may have limited resources or live in rural areas. That data, again, can then be provided to any clinician that is deemed appropriate to have access to it. That could be an OBGYN that's monitoring a pregnant woman who has high blood pressure and is at risk for preeclampsia. It could also be one of our Philips Health coaches, because we do have registered nurses and dietitians that monitor this data and outreach to the users when they see concerning readings. But whoever the end user is of that data is provided to them timely and is relevant for that patient's care in order to help them right there at that point in time, which is really critical with remote patient monitoring. So on the next screen, you can see here that we're really transforming the care delivery system outside of the hospital walls and into the home. Brick and mortar care is really being transformed into a connected network of healthcare providers and information that live in a digital community. Thanks to the adoption of decentralized care delivery, timely interventions, and lifestyle modifications, helping to improve the long-term health for patients, members, and communities. And we actually are already seeing the positive outcomes of virtual care, which is creating significant and positive momentum. In fact, Philips Future Index revealed that shifting to virtual or remote care was a top priority for 65% of healthcare leaders. And this last data stat here too, by 2025, 40% of the nation's care providers will have shifted 20% of their hospital beds to the home, driven by remote patient monitoring. And that was a stat that we actually pulled from him. So how is your state successfully shifting sites of care? I mentioned it all starts really with remote patient monitoring. If you look at traditional disease management programs, which I've spent a lot of time in my career focused on trying to prove outcomes for those types of programs, it's really difficult. And that's because patients would work with a care manager or a provider and talk to them about their concerns at a point in time based on a calendar, right? So they set an appointment to talk to their provider about their diabetes. They set an appointment to talk to their care manager about their high blood pressure. But they typically spend the first 10 to 15 minutes of those sessions talking about the ER visit that happened 6 weeks ago or since the last time they spoke to each other. The education and the feedback that was provided to the patient was not timely. But with remote patient monitoring, we can reach out to a patient when they need the support, right at that right time that they took that reading, and try to intervene and prevent that ER visit from happening to begin with. Numerous studies across the spectrum of telehealth and remote patient monitoring have proven that monitoring a patient's vitals, such as their glucose, blood pressure, weight, temperature, pulse ox, monitoring those remotely leads to better clinical outcomes, reduced readmissions, and overall cost of care. This is because that trained clinician is using that teachable moment with that member when they take that reading to deliver the feedback, the education, the next steps that are needed to prevent the readmission or the ER visit. This is really important when you think about the case that I cited earlier, right? A pregnant woman who has high blood pressure, maybe she works full time, she has other children at home. She's unable to take time off and go to her physician's office once a week or once every 2 weeks to get her blood pressure checked. So she doesn't check it, so she doesn't go to her appointment. Or the senior citizen that has COPD that is unable to find transportation to go to their doctor's office and have their symptoms checked. Or, the patient that has diabetes that was newly diagnosed and is still trying to decipher, what do my readings really mean? For all of these reasons, there is support behind remote patient monitoring. Starts with the American College of Obstetrics and Gynecology, but there are numerous other clinicians that are looking for ways to develop efficient, effective care for their patients. And this market is really growing. There are several new RPM startups that are competitors of ours that are really making a space and a name for themselves in this industry. So we only can guess that this market, this industry is just going to grow from here. So I know one of the questions that the committee had asked is what's happening in other states? So as of today, a little over half of the states, about 34, are reimbursing for RPM through their state Medicaid program. Some are using budget appropriations and some a legislative vehicle for RPM. And the policies and the restrictions definitely vary widely by state. My home state of Ohio is one of the recent states to add reimbursement for RPM, in addition to Arizona, Oregon, and Kentucky. This is a great visual. I wanted to display this map as well as give you the link that you see at the bottom of your screen. The Center for Connected Health Policy is a great resource to go out and check what's happening in other states. What does their policy say? You can actually read specifically the language that is written for telehealth and RPM there. So I would suggest going out and checking out that Center for Connected Health Policy website if you have not yet already. Just to give you an example here of kind of the differences in what you might see in the definitions and interpretations of telehealth and telemonitoring. I mentioned they vary greatly. As you can see here on the left-hand side in Oregon, their RPM language was written very broadly. One little blurb there compared to Minnesota, who wrote a very specific and technical definition for RPM. So we see a wide range. And then when you compare it to what is written for your state, which I'm sure you're all very familiar with, this varies from that as well. It does not include RPM, obviously, at this point in time, but it does state telehealth and how you define telehealth. Again, I would encourage you going out to the Center for Connected Health Policy website just to compare a few more states. Due to the limited time, we just represented these 3, but it's a great resource to look to see what else is out there. But to wrap this up, we just wanted to point out that there is a lot of inconsistent industry nomenclature surrounding telehealth, telemonitoring. And it really is not uncommon for some of these words on your screen to be misinterpreted as RPM, or remote patient monitoring. In order to be clear and concise, we do encourage that remote patient monitoring should be called out in order to prevent confusion, if that is the intention. And with that, I am going to pause and see if there are any questions.
Thank you so much. Do we have any questions? I don't think we do. So thank you so much for your presentation. We'll go ahead and move on to the next one.
Great, thank you so much.
Of course. So in speaking about digital health, I think it's always important to bring it back home to what we're doing in this capacity and in our state. And we do have a startup that is locally based that does work in digital health, and that is the product known as MedWand, who has received numerous awards for some of the innovation that they're doing. And so I wanted to invite them to speak about their product and some of the challenges that they've experienced as a startup. So with us, we have Mr. Stuart English, who is the Vice President of Sales and Marketing. So welcome to Senate HHS, and please proceed when you're ready.
Good afternoon, Senators. Thank you, Mr. Chairman, for the opportunity to tell you a little bit about MedWand and how we're working to advance digital healthcare. As a startup, my comments today are not really going to focus so much on policy or investment or any data recommendations, but rather talking a bit about how our technology enables there to be more clinical feet on the ground. And this is just one of those practical issues of the entire world is experiencing a shortage of nurses and doctors. And a key question is, how do we use the resources that we got to deliver more care to the patient community? So as you mentioned, we are based in Las Vegas. Our company was founded back in 2015 by 2 Las Vegas residents. Robert Rose is our current president and CEO, and Dr. Samir Kamar is a concierge medicine pioneer. And together they conceived of MedWand, founded the company, and through raising money through friends and family, I think to date we've raised about $14 million. Very extensive clinical trials with the FDA. We received 510K approval last summer. So essentially the company has moved to from non-revenue status at the back end of last year to really at the beginning of the sales cycle this year. We have currently about 20 employees. Quite likely that's going to double, maybe triple by the end of the year. Our market that we can approach just for connected devices, and MedWand, this is a MedWand, this is the medical device, connected device. The market in the States is about $8 billion. The market overseas is probably closer to $30 billion. And we forecast that approximately half our sales by the end of 2023 are quite likely to be at overseas hospitals and government entities. So what exactly do we do? Well, as I mentioned, we are involved in what generically is referred to as telemedicine or digital health. But frankly, as has just been mentioned, the industry is rather struggling with that definition because what it tends to limit is the vision of what exactly can digital health or telemedicine be. This phrase too often just gets people thinking of it's a video conference between a patient and a doctor. And that is a very valuable thing. And unfortunately, it's about the worst thing that we could possibly encourage in order to solve the staffing shortage that every country around the world has got. So if we drive every engagement to become a virtual one by video between the patient and the doctor, we do a great disservice because A, it consumes all the doctor's time, and B, the doctor isn't getting what's critical for them to make that evaluation, which is the actual physiological data about the patient, often referred to as the vitals. So what do? Well, basically through the development of this device, which Dr. Kamir asked us to develop to give him the ability to remotely gather patient vitals into what's now known as an asynchronous or on-site exam, or asynchronous or a virtual consultation. By having such a device, a doctor or frankly a nurse or any clinician can gather the patient vitals, and we can start to make the whole process of gathering information, analyzing information, making diagnoses much, much more efficient. So this set of services is now people have been looking for alternative names. So you'll hear quite frequently this phrase virtual care rather than telemedicine. And virtual care is intended to say there's more to it. There's a broader set of services. You may also hear phrases like telemedicine triage. That's trying to differentiate between an initial comprehensive exam, which may then lead into what the last speaker was talking about, which is how do we monitor a patient more continuously in, quote, a remote patient monitoring environment. So there is no one aspect which needs priority over others. They all kind of go together in a holistic grouping. But what is very important from our perspective, and what our customers are commenting to us with ever increasing frequency, is we have to find a way to decentralize the hospital, the medical, clinical team. We've over-consolidated resources in urban centers, in hospitals, and it's driving costs up. It's the most expensive place to have staff. It's the most expensive place for patients to come in, as the last speaker said. Often if you have to come in over distance or at certain times, you just don't. And if you don't make your appointment, bad things can happen for you down the road. It's bad for the patient. It's also bad economically as well for either an insurance company or whoever the payer is. Things that are deferred become very, very expensive very, very quickly. So fundamentally, what we aim to do through our technology is meet the patients where they are. And by doing that, we can lower the total cost of medical services delivery. We can increase the clinical staffing efficiency. And as I mentioned, staffing shortages is a global phenomena. And ultimately, we improve the patient outcomes. If any of you had the opportunity to come to the Consumer Electronics Show and had the opportunity to visit our booth, we launched at that show an initiative which we referred to as the Urban Rural Healthcare Alliance. Now, we mentioned some other brand names at that time, but this really wasn't about a commercial relationship between MedWand and some big names that you would all recognize. This is really about saying we need to reconnect urban centers of medical excellence with communities that are in the field, in the rural areas. And every state, every country has these issues. So this was really received as a very positive development. And I believe our press release at the time received something in the region of 250 million impressions. And since that time, we've been inundated with inquiries about the technology, how does it work, from countries such as Japan and Thailand and India and Nigeria and Turkey and Dubai, United Kingdom, as well as, of course, many regions in the United States. So to conclude this, I would just pose these questions to you. So we were asked, how is it that we as a startup, a Nevada-based startup, can be assisted by government, and what do you guys need to drive this forward to get this further quickly into the market? Well, the first thing I would say is, first of all, we very much appreciate, first of all, Clark County, a very positive attitude, and the state's very positive attitude towards business development. It's fantastic. Keep going. No issues there. In particular, we'd also like to call out the U.S. Commerce Department. We've leveraged Hector and his office and his colleagues around the world to understand who are the right people to be talking to in overseas countries. And in our fulfillment center, it's about a 25,000 square foot facility just near Nellis Air Force Base. We are already set up as a free trade zone. So that really facilitates import export. Are there some things that can be done legislatively or encouraged? The answer to that is yes, absolutely. Number one, the technology fundamentally says that a patient can be treated by a clinician wherever that patient is, wherever that clinician is. That means I have a patient in California and they'd like to talk to a doctor in Nevada, or vice versa. That's not easy. From a technical point of view, we can do that. That's not a problem. The question is, are there licensing reasons why that can't be allowed? Because if there are, it will hold back the deployment of the technology. We have a similar problem internationally, and we have a recommendation that the United Nations basically gets on and produces something which we would refer to as a Doctors Without Borders for telemedicine, frankly, so that any physician in any country can treat a patient. The demand is there, but we can't allow legislation to stand in the way. So from our first question is, are there any policies, adjustments that can be made that would allow Nevada licensed doctors to practice pretty much anywhere in North America? And if that's not possible, simple question, why not? The second one, which was pointed out earlier, data exchange. We collect a lot of very relevant data, but the reality is too much of the industry is siloed, and that data that goes into an electronic medical record is not easily transportable for that patient somewhere else. Although there are, in theory, laws that say you must, in practice, it's actually very difficult to get that. So we really want to encourage all vendors who have EMR capability to freely exchange that data within the spirit of the HIPAA privacy laws. And then just speaking for MedOne specifically, we have a fulfillment center, is a configuration and fulfillment center in Nevada. We do have all of our product manufactured in the United States. Currently, our contract manufacturer is in the East Coast. We would like to bring that operation much closer to our fulfillment center because distance is an impediment to business, this business just as much as it is as an impediment for a patient to visit a doctor. So if there are any avenues to bring more incentives for manufacturing within the state, that will be positively received from our perspective. With that, I'd just like to wrap up these very brief comments. I would encourage anybody, if they're down in the Nevada, in the Las Vegas region, if they'd like to drop in and see our facility at any time, you would be most welcome. And with that, I'd like to offer it back to the committee to see if there's any questions or comments that they'd like to make.
Thank you so much, Mr. English. I think all of us enjoyed your presentation, specifically on what we can do to support companies like yours, because at the end of the day, you are Nevada-based, and we want to ensure that your success is our success. Do I have any questions from committee members? Senator Stone.
Well, thank you very much for your presentation, and we're very proud to have you here in Nevada. Can you just tell us a little bit more about the MedOne device and what diagnostic things does this device do? I assume it takes blood pressures, maybe takes blood sugars, or what kind of vital information can be transmitted? So you mentioned virtual care versus telemed. So tell us how your device enhances the examination and diagnostic processes rather than being in person.
Yes, indeed. So the origin story with Dr. Kumar is...
Mr. English, if you could state your name for the record before you speak, please, so that way.
Oh, yes.
Thank you, sir.
Stuart English, yeah. The origin story for MedOne actually is literally to that subject. Dr. Kumar was talking with his cousin, I believe, in Chicago, and she was complaining of chest pains. And so he was trying to diagnose her and realized that over a video conference, it was virtually impossible. Dr. Kumar at the time was actually the tenant of our current president in his house in Vegas. And they got together one day and just started to talk about, what do you do? What do you do? Well, I run an engineering company. I'm a doctor. What I need is this. Can you build it? And the answer was, yeah, absolutely. We can build that. What do you need? So the feature set on the MedOne is basically those things that you would capture when you go in to see your clinician, your physician. So it's temperature, its stethoscope, its electrocardiogram, its pulse oximeter, which for COVID is really important. And it's also an ultra high definition camera to do inspections of ear, nose, throat. You notice I didn't say blood pressure. There's a reason for that. Ideally, long term, there are technologies coming out such as optically measured blood pressure. So in future generations, we may well see that literally you put your finger on the pulse and it indicates your blood pressure as well as your oxygen values. At this time, that's not technically possible. And if it was, the FDA wouldn't approve it either. So we leverage blood pressure cuffs and glucometers that use little miniature radios, and we consolidate all that information into a portable medical device, which is typically an Android tablet. So this goes together, and the tablet becomes the consolidation point for all of the parameters, those which are MedWand and not. And then that data is submitted from our tablet to our cloud-based servers, and that's where the physicians log in and can see the complete exam result. It's also where we go into the more advanced developments, which is having got the data, there are now software as a medical device companies, commonly known as AI, which can take ECG strips, for example, or stethoscope recordings, for example, run them through their algorithms and will report back to the clinician, yes, this patient has an AFib condition, or this patient has a heart murmur condition. So as we start to expand AI, the trend gets into an interesting one of, are you building a tricorder which kind of replaces doctors? The answer is no. We're offering doctors the opportunity to run a quick analysis. Maybe they're not a specialist in cardio. By running an AI, it can give them some extra data to allow them to make a more efficient, quicker diagnosis.
Thank you very much. I didn't see the prostate attachment to go on there for a prostate exam. I assume you're working on that.
Well, yeah, we are currently working with. It's interesting as we get more and more engaged, we have more and more companies coming to us and saying, "Hey, look, we've got a tool that does this." So, for example, we've had companies that make real-time urine analysis. So there's extra devices now that attach to the toilet bowl, and they can basically start to pass over data into the exam. We've got more traditional things like ultrasound, which is becoming more and more compact and therefore more and more portable. That's true also of X-rays. So we see great promise here for the technology in establishing what I would refer to as a community clinic, a rural clinic, which might even be a fire station EMT technician is actually the operator of it. Starting to put more and more care at the periphery, reducing travel time for patients and just basically increasing the sample rate that we have of measuring what might be going on with a particular patient.
Thank you.
Thank you so much, Mr. English. We have one more question from Dr. Titus. Senator Titus, please proceed.
Thank you, Mr. Chair, and I appreciate the presentation. Having practiced my entire life in rural Nevada after 40 years with the only doc, literally the only provider in 30 miles in any direction. I mean, we didn't even have a pharmacy in any direction, so I had experiences that many people do not get in the profession. And it actually has progressed dramatically from the time when I opened my practice door in 1984, when I didn't even have a fax machine, to now. And so I appreciate what you're trying to do, but again, that cumbersome thing that you showed us, that wand, I can get on my Apple Watch right now for the most part. I mean, an EKG monitor, my pulse oxygen, my heart rate are actually on my watch. And even as I took care of, I still do house calls and take care of the death and dying. And my mother had, as she passed away at 92, in the very home where she was created, we were able to monitor her oxygen level, and it all came to my Apple phone. And so the technology is there to do remote monitoring, and I appreciate all of that, and it will advance. What my concern is the accountability of the provider. I was on our state board of medical examiners. I was a member of that. And one of the things that we were held as a public health official is public safety and accountability. And although I appreciate that there's not enough of us, there's not enough of me or any provider out there, we want to make sure that our providers are accountable to the patients they see. And when we have folks throughout, it's not so much a, they could be 1 mile away or they could be 1,000 miles away. And with this technology, the actual distance doesn't matter. But for me, the accountability matters, whether you're in my office or whether you call me on my phone or wherever you are. So I'm not against somebody being in Florida and giving advice through proper communications. For me, it is indeed a licensure piece, because we need to be able to make sure that that person is competent to give that advice. And if not, and gives advice and there's a bad outcome, we need accountability. So I'm just wondering where you are on that thought process.
Well, the first thing I would say is, far be it for me to speak to the medical industry with the experience I've got. So I would just restrain my comments to as follows. One of the most important things about any patient is this word called care. So yes, there is a touch point. And the first thing, the principle I would say is, if I'm not receiving any care whatsoever, I'm not being served at all. The next comment I would say is, what we're talking about, our technology allows the data to be gathered by the patient, by somebody who's not as medically trained as a full clinician. That doesn't mean that the analysis is being done by that person. That analysis is still being done by the licensed clinician. And yes, there is the issue of do different states have different standards, and I will leave that to you, ladies and gentlemen, much more experience in this to debate. But we definitely see, like we talk about, there are food deserts, there are medical care deserts, and the technology is a methodology to allow us to put data capture out there in the field so that we can get clinical grade data for somebody who is qualified to make those diagnoses. And the more we can make those people's lives, time of day more efficient, the more workflow we're going to get through the system. And that's a beneficial thing. The last comment I would say is, there is indeed a debate about wearables and their value versus clinical devices where we're administrating care with nurses and EMTs and medical assistants. There is definitely a debate there. And the only comment I would offer to that is, as we're engaging with majority of clinicians, they're concerned about the absolute volume of data that may be coming in from wearables, in part their accuracy, in part just the pure volume, in part the patient driving the engagement in perhaps different ways because they're just being overwhelmed by the information that's coming to them. So it's a complex subject. We are confident that what we're bringing to market is of benefit, and that seems to be the response that we're getting from the healthcare professionals that we engage with.
Thank you so much, Mr. English. I think that wraps up our presentation. Hopefully, I think many of us are interested in even seeing the product in person, and perhaps one of our committee members can test the receiving end in evaluating the results. But I think we appreciate the work that you all do. Please communicate that to your team. And whatever if there are issues that you believe that we can help support, please communicate that to our staff, and we look forward to partnering with you.
Again, thank you so much. And then, yes, if anybody would like to experience, it's really simple. Given the technology that it is, it's simple to set up a demonstration for anybody who'd like to, quote, become a doctor and will be the patient, or vice versa. Be happy to do that.
Thank you so much. I really appreciate it. Moving on to our next agenda item, we have a presentation from Paratherapeutics. They have interesting technology which is going to present prescription digital therapeutics. So we have Mr. Mendoza, who is the Director of State Government Affairs, so if you can please proceed.
Thank you, Mr. Chair, and members of the committee, and specifically a special shout out to Senator Stone, who I know I've testified in front of many times when I lived in Sacramento as a lobbyist. So thank you all again so much for having me today. Again, my name is Mark Mendoza, and I'm the Director of State Government Affairs for Paratherapeutics. We're very excited to present today and discuss our FDA-authorized prescription digital therapeutics, or PDTs is what they're called, that treat specifically substance use disorder and opioid use disorder. As you'll see in the handout we've shared today, Reset, the PDT that treats substance use disorder for issues around alcohol and methamphetamines, for example, and our PDT for called Reset-O, specifically treats opioid use disorder, for example, heroin and synthetic opioids. These tools are the only FDA-authorized prescription digital therapeutics right now that treat those aforementioned dependencies. And PDTs are currently being used across the United States, in particular states like Florida, Michigan, Massachusetts, Oklahoma, and the South Carolina Department of Corrections. But what specifically are PDTs? Prescription digital therapeutics are software-based disease treatments intended to prevent or treat a disease that is regulated by the U.S. Food and Drug Administration. Specifically, FDA-authorized PDTs are adjunctive apps that require a prescription from a healthcare practitioner to access the treatment in the application. FDA-authorized PDTs for both substance use disorder and opioid use disorder include, among other things, cognitive behavioral therapy, fluency training, contingency management, craving and trigger reporting features, and also a provider dashboard, which can all be accessed via a smartphone or a tablet. These PDTs help meet patients where they're at, and it can notably be used offline and in Spanish, further helping address equity and access issues across our state. It's also important to underscore that PDTs are not standalone solutions. So they're actually tools that are complementary to regular outpatient treatment and also medication-assisted treatment. Notably, the White House also released their National Drug Control Strategy document last year in April. And specifically within the document, it discusses prescription digital therapeutics and also underscores that exploring tools like this could help increase services for a wide array of patients. Lastly, PEAR has served over 50,000 patients to date across the United States, and has demonstrated via our many published studies that FDA-authorized prescription digital therapeutics improve access to addiction treatment, they reduce stigma associated with addiction treatment, create cost savings notably for a state, and increase overall healthcare outcomes for patients, such as treatment, retention, and abstinence upon completion of the PDT program. We're very happy to share those studies upon the committee's requests. Thank you again, Mr. Chair and committee members, for allowing PEAR Therapeutics to testify today at today's informational hearing, and I look forward to answering any additional questions about our tools. Thank you.
Thank you so much, Mr. Mendoza. Do we have any questions from committee members at this time? Mr. Mendoza, I think really quickly, I know we privately discussed this. So if you are a patient, do you receive access to an application, and is that application collected to the EMR that the physician can see? Like what does that look like for the patient experience and to the physician?
Yeah, no, that's a great question, Mr. Chair. So when a patient goes in and a provider deems that a prescription digital therapeutic is an appropriate treatment for that patient, they will typically write that prescription via online, the PEAR portal, that then will send specifically an access code to the patient's cell phone. So similar to when we log into our bank or to our email, right, we're given like a 4 to 5 number access code. That is the equivalent of a prescription, but in a digital setting. And that access code is not only unique to the patient, but also to the provider. Once the patient actually starts completing the treatment after downloading the application off the Google Store or off the Apple Store, all of the information that's being fed into the prescription digital therapeutic by the patient is also showing up on a provider dashboard. So again, the provider that originally wrote the prescription for the patient can see when they're completing their cognitive behavioral therapy modules, how many contingency management incentives they may have gotten. Are they reporting any cravings and triggers? And all of that information really gives a bird's eye view into what's going on at home when the provider is not face-to-face with that patient. And again, all of that data in the dashboard that we're talking about seamlessly integrates with quite a few EHR systems that I know our team has worked really hard on to make sure that information is easily being transferred over. So that's sort of typically how the process looks. But again, our PDTs run on a 12-week course of treatment. So, most of the patients actually only need one fulfillment of the prescription digital therapeutic. But as we know, recovery is not linear with this disorder that we're talking about today. So there is a scant amount of patients that will ask for a refill of those prescriptions sometimes.
Thank you so much. And then just a quick skim of what's happening federally between different states. Are you noticing that certain states are starting to enact specific reimbursement for PDTs, or are they doing pilot programs? Like, what do you see in general in terms of the scope?
Yeah, no, again, great question, Mr. Chair. Most states have been starting with a pilot program because right now, not all commercial plans cover this treatment just yet. And Medicaid and Medicare does not have a benefit category for a treatment like this. So in the interim, because we know across the country, regardless of where you live, overdoses continue to spike. States have felt that PDTs are another tool in the toolbox to combat the overdose pandemic that we're seeing across the country. And so typically most have started with a pilot program, and upon completion of a pilot program are either seeking guidance from CMS on how to make something like this a benefit for their Medicaid population, or in some other states have already just decided, via other appropriations to make this benefit available indefinitely.
Thank you so much. And I look forward to having that conversation as well. I think the patients of Nevada definitely need a service like this. And as more PDTs continue to be onboarded and approved by the FDA, I think that's a conversation that we should definitely be willing to have. So thank you so much for joining us here today. And then last but not least, we have, we started off today talking about public health modernization. And one of the groups that is doing that work in Nevada is Unite Us. So we do have an individual that can help present it. So we have with us Ms. Linda Hashef, who is the Nevada State Network Director. So please proceed when you're ready.
Okay, thank you. I'm going to get this started.
The committee members have the exhibits, so you can
Good
proceed.
enough?
Yeah.
Okay. All right. Thank you so much. I appreciate, all the previous presenters too and the valuable information they shared. I think as we can hear, it's a really important topic, and appreciate you setting up this day for us to share our information as well. Thank you, Chair Donate and the entire Health and Human Services Committee for the opportunity to testify this afternoon. My name is Linda Hashef, and I am the Nevada State Network Director for Unite Us. I come to this work with more than 25 years of experience in the community services field in Nevada, including being a co-author of the Elders Count report published by ADSD in 2021, and serving in leadership and development roles with the Center for Healthy Aging and Opportunity Alliance Nevada, among others. I'm really looking forward to this opportunity to share some more information about Unite Us and how we support communities in Nevada and across the country to improve their health and well-being. So as the others have really addressed some of the clinical side of the issue, I'd like to talk about the need for identifying and addressing residents' social care needs alongside their health care needs, It's really critical to improving outcomes for our Nevada residents. As you are likely aware, research suggests that most of our health outcomes are driven by non-clinical factors, including our level of education, where we live, how much income we have, and the family and social supports we have access to. However, most of our healthcare spending is directed toward clinical settings. On slide 2, you can see that we address the social needs that drive our health outcomes. We need to understand those risks at a local, I don't know if anybody can see this, I'll do it, at a local and even individual level. Our analysis, which I'll describe in more detail later, indicates that more than 1 million adult Nevadans are socially and economically vulnerable. This comes from information from March of 2022. These individuals include more than 300,000 residents with substance use challenges and co-occurring social needs, and 18,000 new mothers who are socially vulnerable. Furthermore, these challenges are more prevalent in certain areas of the state. For example, in reference to our rural representative here today, Lyon County has approximately 22% of adults that have both substance use and social needs. It is imperative that we address these and other sources of need for our urban and rural residents. At Unite Us, we focus on addressing health and social needs through end-to-end infrastructure. We provide technology tools and data that can help to proactively identify individuals' needs, connect them to services that address those needs, track receipt of services, and whether needs are met, and facilitate invoicing for those needs. We are already supporting Nevadans and communities across the state through the Unite Nevada network. The network has served over 1,500 individuals in less than a year and a half and includes about 200 local organizations with over 400 programs offering housing, behavioral health, food assistance, family support, and a range of other services. Among the organizations that have signed on and are serving individuals through our network include HopeLink of Southern Nevada, the Economic Opportunity Board, 3 Square Food Bank, Reno Housing Authority, and Nevada Legal Services, to mention just a few. Because we set network standards for organizations that join Unite Nevada and offer a true closed-loop system, we can identify when needs are actually being met, what gaps in social care exist, and how different racial, ethnic, and other demographic groups are being served. Unsurprisingly, housing-related needs are the most common ones identified through our Unite Nevada network, followed by needs for clothing and household goods and food assistance. In addition to offering an any door or no wrong door approach to help these individuals who are already seeking support, it is critical to be able to proactively identify individuals with elevated health and social risks. Doing so can support community-level resource planning as for public health or social services, and facilitate individual-level outreach to help residents access needed services. We are able to identify individuals and community-level social risks using our social needs system, or SNS. SNS is an analytic framework leveraging the industry's largest integrated health and social care database to systematically predict and measure social, environmental, and economic vulnerability. 12 factors, including food insecurity, transportation needs, insurance status, and loneliness, drive each individual's composite SNS score. This analysis can also be summarized at a local or regional level to identify community-wide needs. Collectively, the ability to identify needs, enroll individuals in services, provide those services and measure impact, to do all of those things in a measurable and accountable way is critical to improving health and well-being in Nevada. This feedback loop is important to ensure that individuals receive the services they need and deserve, and to support communities in understanding the gaps in their health and social care infrastructure and plan interventions accordingly. We are glad to facilitate this work through the Unite Us national scale and hyper-local community work here in Nevada. But in closing, I'd like to say we really appreciate the legislature for holding this Digital Health Day and creating the opportunity for Unite Us to discuss how our end-to-end tools can help to improve health and well-being across the state. We really encourage the legislature to consider funding for social care collaboration technology that enables cross-sector care coordination on behalf of residents in need, including by proactively identifying individuals with high health social risks, connecting them to services that address those needs, tracking receipt of services and whether the needs are met, and facilitating invoicing for those services. Such funding would help to improve health and well-being for individuals across the state, and we'd be glad to offer our expertise from working with states across the country to support this effort. With that, I just want to thank you for listening and for your time, and see if you have any questions.
Thank you so much. Any questions from the committee members? We don't have any, but we appreciate the work that you do, specifically in the social determinants of health. So thank you so much for joining us here today.
Thank you.
Okay, committee members, we have one last agenda item, which is an introduction of a committee BDR. They are in the red folder that you have. So as you know, throughout session committees, we are asked to introduce bill draft requests to begin the bill process and assign a bill number and get it back referred to our committee. I will say that your vote to introduce a BDR is not an indication of your support. It's just to get the bill printed and assigned a bill number. So today we have BDR 39-312, which revises provisions relating to crisis intervention. So do I have a motion to introduce?
I would so move.
Thank you so much. We have a motion from Senator Nguyen and a second from Senator Stone. Any discussion? Motion. All those in favor, please say aye. Aye. Any opposed? Motion carries. Moving on to public comment. Is there anyone in this room that would like to provide public comment at this time? Please proceed.
Thank you, Senator. Committee members Dan Musgrove with Strategies 360 here on behalf of Pear Therapeutics. I want to thank the chair for allowing Mr. Mendoza to present on behalf of Pear. But since this is a policy committee, I did, since you kind of opened the door, I wanted to let you know that since we have two members of finance sitting on this committee, we are working with the governor's office, speaking to them, as well as we're going to begin speaking to members of Finance and Ways and Means to talk about that pilot program. We think it would be very, very important to begin a 2-year pilot program here in the state of Nevada using the PDTs. We're looking at $5 million for that to buy essentially those subscriptions that you talked about. And we think that it'd be very well received. We've talked to a number of the courts throughout the state, the drug courts, substance abuse courts. We've talked to Clark County Social Services and other such governmental entities, including corrections, and we think that it'd be absolutely well received. And at some point, we hope to get this legislature's support on a pilot program. So thank you, Senator, for your leadership on this. I know Dr. Titus has met with the folks before as well. And again, I think it's something that Nevada needs to look at as well as other states.
Thank you so much. Anyone else in Carson City for public comment? Moving on to virtual, LCB.
Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. I don't have any member comments, so that concludes our meeting for today. Our next meeting will be Thursday, March 9th at 3:30 p.m. So thank you so much, and meeting's adjourned.